Welcome to the 2018 National Lead Poisoning Prevention Week webinar series. Each year, the U.S. Department of Housing and Urban Development, the U.S. Environmental Protection Agency, the Centers for Disease Control and Prevention, the USDA, NEFA, and our partners collaborate on a national outreach effort to observe National Lead Poisoning Prevention Week, held this year from October 21st to 27th. National Lead Poisoning Prevention Week is an annual call to action aimed at bringing together families, individuals, community-based organizations, state, tribal, and local governments, and others to increase lead poisoning prevention awareness and to increase efforts to reduce childhood exposure to lead. National Lead Poisoning Prevention Week also highlights the many ways parents can reduce children's exposure to lead in their home environment and prevent its serious health effects. This year, the three National Lead Poisoning Prevention Week themes are Get the Facts, Get Your Home Tested, and Get Your Child Tested. For more information about National Lead Poisoning Prevention Week, including resources for your program, you can visit www.hud.gov/healthyhomes. This webinar is Get Your Child Tested. This webinar will last approximately 45 minutes with 15 minutes at the end for questions for a total of 60 minutes. At the end of the webinar, you will be given information on links to additional resources for your program. We will be recording this webinar and posting it for you for later viewing if you prefer, or for others that would like to view it that could not make it today. Finally, your microphone will be muted during the presentation. This is because we have over 200 people attending. If you have questions during and after the presentations, please feel free to post them in the question window and I will read them to the presenters. And we'd prefer to do this at the end of all four presentations. So I'd like to introduce our speakers now. Dr. Jennifer Lowry is a pediatrician and toxicologist at Children's Mercy in Kansas City, Missouri. She is the director of the Mid-America Pediatric Environmental Health Specialty for Region 7, Missouri, Kansas, Iowa, and Nebraska. Dr. Lowry currently serves as the chair of the Council on Environmental Health for the American Academy of Pediatrics. Ms. Mary Beth Hance is a senior policy advisor in the Division of Quality and Health Outcomes at the Centers for Medicare and Medicaid Services. She has worked at CMS for 28 years and is the lead on Medicaid lead screening policy. Dr. Sharonda Buchanan is the director of the Office of Priority Projects and Innovation in the immediate office of the director of CDC's National Center for Environmental Health, Agency for Toxic Substances and Disease Registry. Dr. Buchanan has worked in the area of childhood lead poisoning prevention for more than 25 years, first as a chief of epidemiology and surveillance section of CDC's Childhood Lead Poisoning Prevention Program, and later as director of CDC's Division of Emergency and Environmental Health Services, where the Childhood Lead Poisoning Prevention Program sat for more than a decade. And then we also have Ms. Nsayadu Obat Witherspoon. She serves as the executive director for the Children's Environmental Health Network, CEHN, where her responsibilities include organizing, leading, and managing policy, education, training, and science-related programs. For the past 18 years, she has served as a key spokesperson for children's vulnerabilities and the need for their protection, conducting presentations and lectures across the country. She has served as a member of the NIH Council of Councils and is a current member of the Science Advisory Board for the Centers for Disease Control and Prevention, among other memberships and affiliations. So we will start with Nsayadu, and you are ready to go.
Thank you so much. Good morning and good afternoon to everyone, and thanks for joining us today. Just trying to advance my slides, and they're not advancing, so hold on, please. Michael, sorry, it seems everything seems to be frozen on my end.
Could you try advancing one of the slides with that arrow?
The orange arrow, it's not moving.
Okay.
Are you able to move on your end, just so I don't
not
hold
on my
up
end. I mean, I could bring up your presentation. Let's do this. Give me a second to pull it up because I can probably do it on my end here. Give us a few seconds. So what I'm going to have you do is you will just have to tell me when you want to advance a slide. So,
Sure.
And I need to make myself a presenter.
I just moved. Are you all seeing the second
Actually,
slide now?
actually, now we are. We're seeing the Nelson Mandela slide, so it does seem to be
Okay, good.
working on that. Okay.
Good. Okay, thank you. So I bring up this quote here because protecting children in general. We always say at the Children's Environmental Health Network, it's great and very honorable to do the work that we do, but really we don't want to be around for a long time. We want our work to be interwoven in a very natural way into our federal, state, city, and just overall modes of work. But on those harder days, I try to remember this quote here that there can be no keener revelation of a society's soul than the way in which it treats its children. And I think we could all admit that we've come a long way regarding public health best practices and reducing exposures to lead, but we're nowhere out of the woods on that and definitely have much more to do for our vulnerable children. The Children's Environmental Health Network is a national nonprofit organization. We've been around going on 30 years. Our mission has always been the same, to ensure that we protect the developing child from environmental hazards, and we consider all environments, the built, the biological, and the chemical that they are exposed to. Our work is conducted through promoting and supporting and at times participating in preventive research, educating and training, so translating that research into application, and of course promoting child protective policies at the federal and the state levels. So just so that we're all clear, of course, a child's environment of all sorts can have a positive and or negative implication on that child's health and safety and well-being. We know that there are various windows of susceptibility, and just to not assume that in the growth and development of a young fetus and child, the timing by which a child is exposed, in this case to lead, can also have ramifications as far as the severity of that exposure. So how are children exposed? We do know that lead, again, is an odorless, colorless, toxic metal, and it's found in a variety of different modes. In particular, old lead paint, house dust or building dust in general is a big route of exposure. Certainly there are particulates of all sort, and also old lead piping in the country and water exposures, the Flint and many other cities. Washington, D.C. has also found some trouble with this over the years. We know that the past contamination, especially also in soil in particular, continues to exist, and the remnants of that in those exposures are very real to children. In particular, also thinking about consumer products as well, and at times lots of different forms of lead found in the products that children are utilizing and putting in their mouths, and having their hand-to-mouth behavior. And also children are on the ground and they have a lot of connection to the floor and soil, and all of those behaviors place them in harm's risk. So if you look at this table here, you'll see that the major modes of pathway for children's exposures to lead, if you look at the first 0 to 6 months, the light green are the non-dietary exposures, so the paint from lead dust and soil, and also the brown on top are exposures to water. But then when you look at a child between their 1 and 2 years, you'll see where the exposures to paint dust increase significantly, and you still have other exposures for sure. So at the end of the day, we want to reduce all levels of exposure to lead in regarding children, and we do know that there's no safe level of lead. And we're also reminded through various publications, but also the Journal of American Medicine, that even small, low-dose exposures are also causing significant impacts in reduced IQ, increased hearing and learning disabilities with children, increased hyperactivity, and also other behavioral concerns. And of course, we still have major injustice issues related to lead poisoning. So if you are a child living within a low-income family in an older home or apartment with old lead-based paint, and if you happen to, on top of that, be African American, you are extremely at high risk. At the Children's Environmental Health Network, we are focused on all children, but certainly acknowledge and think about our strategic work, in particular to the highest risk children as well. So we at the Children's Environmental Health Network work to educate homeowners and in particular child care professionals through a program I'll tell you about in a minute on first how to identify and test their homes and or facilities for lead, and then training those either homeowners and or small business child care providers on how they can reduce the lead toxicity that the families, that the children they're serving, and the occupational hazards that it pertains to those that are working in those environments may come into contact with. The Eco Healthy Child Care Program is a program that we launched over a decade ago. Really proud of this program. We work to identify an information gap where overall child care professionals were not receiving in any regular way training and education on environmental hazards, lead being one of many. So we help assess, what is going on in their physical environment, and again, what are low to no cost steps, realistic steps that they can take to address those concerns immediately. And we're trying to just empower and educate these professionals and parents, because this is, in many cases, this center is a home environment, and encouraging them about how they can also be positive stewards and champions for themselves, their families, and within their communities on these issues. In our trainings, we also highlight a lot of available resources, just as just one of many, but we acknowledge that lead exposures can also happen inadvertently through repair and renovation, especially of older housing and building and schools and things of that nature. So this renovate, right, repair type of guidance out of the EPA is just one of many that we encourage. There are a variety of states that do require licensed child care facilities to submit evidence that they have actually tested for lead during the licensing and or license renewal process, and these are just a few states that do that: Rhode Island, New Jersey, Connecticut, and Vermont, but we are looking to have every state in the nation follow such guidance for sure. It's also important to not only test, but of course disseminate the results of the testing so that parents and guardians and community members are well aware of the situation. And there are certain states that do require child care facilities to notify their parents and guardians, and they are listed here. But again, our whole aim is that these are not unique situations, but the standards and the norm, so that everyone is on the same page and has an idea of what their potential exposures and that of their children could be, and how they can be a part of the solutions to reducing that exposure. There are a number of states that do require the child care facility owners or operators of licensed child care to conduct education and outreach activities related to lead poisoning prevention, and we highly encourage that, because child care providers are a great ambassador for any and all of these issues, in particular lead. And there's a few of these states listed here, but again, we're working to increase that number. And we know that without new funding and capacity, the cost of removing lead taint, if that is really deemed to be the course of action, dust and soil hazards can be a hardship, certainly for schools and child care owners and homeowners. So there are a variety of grants, capital improvements, and resource opportunities out there. I'd say more than there were, even 10 years ago or less. So when possible, we try to link community members and business owners to those resources to help alleviate their challenges in overcoming the exposures. We might also suggest that a child find type of resource is important. For example, in Connecticut, the universal screening is the law, and the Department of Education works with school districts and the Connecticut Parent Advisory Advocacy Center to really find, again, joint solutions for their community, which is a great partnership, and finding those type of alliances and partnership and leveraging is always encouraged. When we look about moving into policy and action, we highly encourage, of course, enacting any mandatory blood lead testing before a child enters any form of child care or school environment, and adopting the Eco Healthy Child Care Program best practices. We have 16 topics on environmental health. Lead is a huge component in our modules and education. And certainly incorporating traditional and maybe even non-traditional players in this, so parents, grandparents, encouraging them to be part of their community advocacy, various committees at the community level to really encourage movement forward on these fronts. And of course, many of us in the advocacy community are working to help pass laws at the city and state level that mandate testing for lead in school drinking water, among other municipalities. There is this report that was just released in July 2018 by the General Accounting Office that does identify that 41% of our school districts in this country had not otherwise tested for lead prior to this report, and then 43% of school districts serving 35 million children did actually test for lead in this process. And then there was a good 16% that don't even know if they test. So that is a problem. We need to have some fundamental baseline of information, especially in places where kids are spending a majority of their time, like a school building. We know that there are at least 9 states, including the District of Columbia, that have taken some action to test school drinking water at the tap. And they are listed here, but of course we want that to be every state and city. And New York actually requires testing and remediation of TAPs in their schools and school-based childcare, and that there are funds in their state budget and results are actually posted online. So that's really seen as one of many best practices. Transparency is there, funding, at least for right now, is there, and the overall political will to really get to the bottom of the exposures in many cases. We highly promote the 3 T's to test for lead: training, testing, and telling among any of our stakeholders, including small business owners and homeowners of all sorts. There is the Lead Service Line Replacement Collaborative. That's another collaborative that we are a part of that's just trying to work to expedite the removal of lead-based piping in this country. And there's a whole website if you are interested in Googling that. We also try to model some cost-benefit packages and examples, because that's usually the biggest hurdle to overcome, how to pay for the removal of the old lead piping. We actually pulled together a group in December last year. The first time that early learning leaders, childcare associations came together with K through 12 school association leaders to talk about lead prevention and remediation. And it was surprising, but it was important. So there is this report available that offers up high-level recommendations that school districts and childcare association professionals could consider in their work and planning. And also, Environmental Defense Fund did have a pilot project recently that looked at the critical need for testing and remediation of lead related to water exposure in child care facilities, and that report can also be found at their website. So there are a variety of resources and baseline examples available to us that we highly encourage and hope that will be useful to you all as well. Thank you.
Thank you, Nsayadu. That was fantastic information. So the next presenter will be Sharunda. I'm going to make her the presenter and unmute her microphone. Can you hear me okay? Sharunda, can you hear me okay? There you go. Perfect.
Yes. Can you guys hear me? Yeah.
Yes. So
Great.
You are ready to go.
All righty. Can everybody see my screen?
Yes, we can.
Thank you so much for the introduction. And for the very next few minutes, I'd like to focus on various aspects of CDC's childhood lead poisoning prevention program's work related to getting your child tested. And I'm also trying to advance the slides. Let's see.
We're actually still seeing you as if, okay, we're actually seeing both. Do you want to go to slideshow and then, yeah, at the top, slideshow. There you go. Then from beginning.
Got it.
There
Great,
you go.
Everybody okay?
Yeah. Now, one more quick one. Go up to the top where you see it says display settings.
Yes.
And then say duplicate slideshow. That way we won't see the next slide coming up. We'll just see, oops. Okay, there we go. Perfect. Okay, you're ready to go.
All right, everybody. Again, I just want to thank you for the introduction. And again, for the next few minutes, I'd like to focus on at least 3 very important aspects of CDC's childhood lead poisoning prevention program. I provided for you just an overview and section this off as 1, identification and early intervention, surveillance and monitoring, program and laboratory improvements. All righty. All right, having a little bit of technical difficulties here. You guys still with me?
Yeah,
Hello?
we're still with you. We can see, we're on the slide that says lead program activities.
Yes. I just want to talk about historically for just a few minutes. Since the passing of the Lead Contamination Control Act in the 1980s, CDC has provided funding to state and local lead poison prevention programs to promote testing and conduct surveillance. We also support the Centers for Medicaid and Centers for Medicare and Medicaid Services requirement that all Medicaid-enrolled children be screened for blood lead levels at 12 and 24 months. And I believe my colleague is going to talk more about that in the next few minutes. To date, CDC continues to provide guidance and technical assistance to state and local health agencies and stakeholders in the area of lead poisoning prevention. We also provide epidemiological and laboratory expertise and monitor trends in blood lead levels. I can't stress enough how important it is to get children tested. Though we aspire to primary prevention and removal of all sources of lead from children's environments before they are exposed, we know that there are still children out there that are at risk. We must identify these children by testing and intervene as soon as possible. Again, through a number of its activities, CDC's cooperative agreement actually works with state and local programs to do just that. CDC funds approximately 53 state and local childhood lead poisoning prevention programs, including Flint, Michigan, to conduct surveillance. It's not quite a complete national program, but we're well on its way. Why must we conduct surveillance anyway? We hear often that CDC uses two main focus of surveillance, national and state-based systems. Why collect the surveillance data anyway? Of course, we want to describe incidence and prevalence. We want to monitor care and coordination of individual children. We want to evaluate the effectiveness of interventions, identify local program needs, identify areas to target preventive interventions, and of course, track progress in meeting our objectives. CDC is well known for its surveillance, and we use two main sources of data to identify children. Primarily, we use the National Health and Nutrition Examination Survey, better known as NHANES, as well as our very own Childhood Blood Lead Surveillance Database. These states provide de-identified data to CDC on blood lead levels and a number of children tested on a quarterly basis. The National Health and Nutrition Examination Survey, we often hear about that. And what is it exactly? It's a program of studies designed to assess the health and nutritional status of adults and children in the United States. The sampling in the U.S. is conducted annually, and data is released in 2-year intervals. NHANES is examined a nationally representative sample of about 5,000 persons across the country each year. Since 1976, NHANES has measured blood lead in the U.S. population, and this exposure surveillance data has played a large role in regulations and public health interventions to decrease sources of lead in the environment. Utilizing NHANES data, CDC has adopted its blood lead reference value, and this was adopted in 2012, utilizing the 97.5 percentile of children ages 1 through 5 in the U.S. population. This next slide demonstrates that the U.S. population of blood lead levels have declined over time, due in large part, we believe, to successful federal policies aimed at reducing lead in the environment. The next slide depicts the accomplishments of meeting Healthy People 2020 objectives. As you can see, the objective to reduce by 10% blood lead levels in the 97.5th percentile of children ages 1 through 5 years have been met. The baseline has been met, and we're continuously trying to drive these levels down. Also, the objective to reduce the geometric mean of blood lead levels in children ages 1 through 5, the baseline target has been met. We want to continue to drive blood lead levels down and continue to reduce the geometric means between majority and minority children. As INSAE said, disparities in children's blood lead levels still exist. Disparities still exist affecting non-Hispanic Blacks and low-income children. The poverty-to-income ratio is greater for non-Hispanic Blacks than any other race, ethnicity, as shown here. And we also depict this data from the National NHANES survey. The risk is not evenly distributed across the U.S. Here you see estimates of lead poisoning in children based on data from blood lead tests conducted by medical providers. Lead testing is not required for all children in the United States. State testing guidelines vary, and not all states report lead testing data to the CDC. Therefore, estimates based on lead testing data are incomplete. The reference level that I just spoke about, currently 5 micrograms per deciliter, is the blood level at which the CDC recommends action be taken to remove sources of lead from a child's environment. The reference level is not a safety level because no amount of lead in the body is safe, and harm can occur at exposures beneath the reference level. In the past, childhood lead poisoning has often been viewed as a problem confined to the Northeast and Midwest. Contrary to this perception, our research shows that lead poisoning impacts children in all regions of the United States. Based on our research, we estimate that the Northeast and Midwest regions identified the highest number of lead-exposed children. The South had the highest number of children with lead exposure, yet identified only 25% of them. The West had the fewest number of lead-exposed children, but performed the worst at identification, with only 22% of the lead-exposed children identified. States with lower rates of lead-exposed children may still have hotspots. Another reason for getting children tested. We need to identify them and get them connected to the services as soon as possible. This slide depicts surveillance data reported to us by our program grantees or awardees, in essence, childhood blood lead surveillance data. As noted earlier, not all states are funded by CDC, thus not all states report data to us. Also, for states that do not report to us, not all blood level data is reported. Some states only report elevated levels above CDC's reference value. This data depicted here has been cleaned, analyzed, and loaded onto our website. It's an example of the number of children tested, as well as the number and percentage of children with confirmed blood levels. And we can also see the decreasing trend over time. We hope that this trend continues, and we want to make sure that we're testing the children and identifying them as fast as possible. I want to talk a little bit about how we can promote the testing of more children. The program and laboratory work being done here at CDC behind the scenes, so to speak, has done a number of things to improve data collection and data reporting. Not enough time to actually present it here, but the lab has actually produced a new video. Our lab has produced this video particularly to help healthcare professionals understand and adopt blood lead collection practices needed to attain accurate results when tested for lead. I would encourage everyone to go to our website, and you can actually click on the new blood lead collection video and have a very nice time viewing it. Factors affecting blood lead data quality. This is very key. CDC is working with its state and local program to understand factors affecting blood lead data quality, including its testing and reporting laws, the context upon which they report, as well as adoption of action levels. Also, we want to make sure that we're doing everything we can to get as much data as we can as you are out there testing and getting the children tested. In summary, the U.S. population blood lead levels, as evidenced by NHANES data, continues to fall. This is a very good thing. Even so, there's an estimated 500,000 children ages 1 through 5 years, or 2.5% of the population of children in that age range, exposed to more lead than the other 97.5% of children at the same age. This estimate does not include younger or older children or other groups at high risk for adverse effects of exposures, such as pregnant and lactating women. In addition, we know that there are risk factors that put children and others at higher risk for exposure. These include age, race, ethnicity, poverty status, older housing, etc. Racial and ethnic, socio-demographic, and geographic disparities in exposure to lead as measured by blood lead levels still exist. We also know that many of these high-risk children are not being tested by healthcare providers and therefore not receiving the opportunity to the appropriate services. We desire a better job at promoting screening, and by that I mean actual blood lead testing, and improving surveillance and monitoring of children until and unless we can do a better job at removing the lead hazards from the environment. Overall, I encourage us to get our children tested. Again, testing is key to eliminating or eradicating lead poisoning or elevated blood levels in children. Get your child tested, and let's work together to eliminate harmful lead hazards from children's environment.
That was fantastic. Thank you, Sharonda. Mary Beth, I'm going to go ahead and make you the presenter. So go ahead and accept the pop-up. Perfect. Okay, you're ready to go.
Great, thank you. I'm going to speak about Medicaid's blood lead screening policy as well as the Children's Health Insurance policy, a little bit about Medicaid blood lead screening data, and then some activities that states and other stakeholders can do to improve blood lead screening rates. Let me start off by giving an overview of the Medicaid Universal Lead Screening Policy. As my colleague Sharonda from CDC stated earlier, all children enrolled in Medicaid, both Titles 19 and 21, are required to receive blood lead screening tests at ages 12 months and 24 months. Any child between the ages of 24 and 72 months with no record of a previous blood lead screening test must receive one. To clarify, the Medicaid requirement is only met when the 2 blood lead screening tests or the catch-up are conducted. Completion of a risk assessment does not meet the Medicaid requirements. I know there has been confusion about this in the past, and we want to emphasize that very clearly today, that to meet the Medicaid policy, it does require the blood lead screening tests. They can be administered in the physician's office. All test results should be reported to the state's Department of Health for inclusion in surveillance data. A little more detail on Medicaid coverage. Under the Early and Periodic Screening, Diagnostic, and Treatment benefit, Medicaid provides comprehensive coverage of any service described in Section 1905A of the Social Security Act that is medically necessary to correct or ameliorate defects in physical and mental illnesses or conditions identified by screening services, whether or not the service is covered under the state plan. This means that Medicaid will pay for services that are needed for children who have an elevated blood lead level. Medicaid also, pays for lead investigations in the home or primary residence of a child with an elevated blood lead level. Lead investigations must be conducted by a credentialed health practitioner who meets state qualifications. Medicaid does have a targeted policy for states that can demonstrate that the risk of lead exposure is focused in certain areas of their state, which was emphasized by the slide that, again, my colleague from CDC showed a few minutes ago. If a state has data to support this, they can submit a proposal for a targeted lead screening plan to the Centers for Medicare and Medicaid Services. To assist states, we've worked with CDC and have developed detailed guidance that's available at the link on the screen on Medicaid.gov. All state proposals are jointly reviewed by CMS and CDC. To date, Arizona is the only state with approval to target lead screening. The Children's Health Insurance Program also has blood lead screening requirements. For children in separate CHIP programs, blood lead screening tests should be conducted according to the periodicity schedule selected by the state. States often use the Bright Futures periodicity schedule, which recommends blood lead screening tests at 12 and 24 months for children at risk or in high prevalence areas. Some states offer EPSCT benefits for children enrolled in separate CHIP, and in that case, they should follow the Medicaid Universal Screening Policy, which, to remind you, is blood lead screening tests at 12 and 24 months. While separate CHIP programs do not have the same universal screening requirements as Medicaid, we encourage states to align their Medicaid and CHIP policies. Data recording. Blood lead screening data for Medicaid children is reported to CMS on the 416 form, which is the reporting form for the EPSCT program. It is extremely important for states to submit accurate data. States are required to report data that includes services reimbursed directly by the state. This requirement applies regardless of whether the reimbursement happens under fee-for-service or managed care. States can report data from the HEDIS lead screening measure on the 416 form. According to the 2017 data on the Form 416, approximately 45% of children ages 1 to 2 enrolled in Medicaid received blood lead screening tests. These are children who are continuously enrolled in Medicaid for 90 days. I do want to add a caveat here that, again, this is blood lead screening tests that are paid for by Medicaid. We do recognize that there are many children who are enrolled in the Medicaid program who received blood lead screening tests that were not paid for by Medicaid and therefore would not show up in this data source. So just wanted to make that note. There is also a blood lead screening measure for 2-year-old children in the HEDIS measure set. And those are for children who are continuously enrolled in Medicaid for 11 months. The 2016 data for this measure shows a screening rate of 67.6%. There are a number of activities that states and other stakeholders can take to improve blood lead screening rates. Some state-specific activity would be to review and understand the data submitted on the CMS 416 and to ensure that it is accurate. States and providers could review language in all coverage materials, manuals, periodicity schedules, and on websites. Collaboration with state health departments and lead poisoning and prevention programs are key to improve blood lead screening rates. There are other partnerships that could also be used, such as partnering with providers and others in pediatric healthcare. Managed care plans can be engaged. Health services initiatives through the Children's Health Insurance Program is another way to address blood lead screening and to improve rates. Leveraging partnerships with additional providers such as WIC, local health clinics, and FQHCs. And another suggestion is collaboration with state housing departments on lead abatement. It is important to note that accurate state data on the prevalence of elevated blood lead levels is necessary to apply for lead abatement grant programs. So accurate data is extremely important. The Children's Health Insurance Program has health services initiatives, which are state-designed initiatives to directly improve the health of low-income children under age 19, and typically focus on preventive services and interventions. Many states have chosen to use HSIs to focus on lead screening. Examples of state efforts include lead abatement, promotion of lead testing through education and awareness, lead poisoning prevention programs, lead-safe housing registries. CMS has coordinated with HUD and other federal partners to assist states as they develop these programs and to assist with review of proposals. And that's the end of my slides.
Okay, thank you. So Jennifer, I'm going to shift over to you. Go ahead and accept the pop-up window. Fantastic. Okay, you're ready to go. Oh, hold on. I'm sorry, I had you muted. I'm sorry about that. So you're ready to go now.
Good.
You're ready to go now.
I'm ready to go. All right. So I am speaking last, and I was trying to figure out a way for this presentation to kind of sum up everything and to kind of show you the real world of how this might work. And so hopefully this will help. I'm going to talk about different sources that are not thought of, and then also I want to describe the role of the healthcare provider in that screening and testing. Kind of got back and forth that Mary Beth alluded to, and why it is really important that we do the testing in addition to the screening. So NSA talked about this a little bit already, but, you know, looking at how children get lead poison today. And I think we would all agree that lead-based paint is still the primary source for children to have lead exposures. We also know that lead is on the ground, and so outside when kids are playing in the soil, they're going to have peeling paint chips from their house. They're going to have past use of leaded gasoline, where especially if their homes are near highways and or close to industrial sources like lead smelters, those are going to settle into the soil and be incorporated into the soil. And then lead solder just from out in industry as well. And we have a number of kids, right, that NSA mentioned have high hand-to-mouth activity, and they play in the dirt all the time. Or we even have our gardens that we're reusing that soil. And if you have a garden that is near a highway, it could be that has lead soil, and so we need to consider that lead could actually be incorporated into the plant itself. And so having different soil come in or have a raised garden is always important as well. But there are other sources that a lot of people don't think about, and some get missed when we're just asking those screening questions that we'll talk about. So these are a number of different, I am a practicing physician who sees patients with lead poisoning quite often. And so these are other sources that we find when we see our patients. So they could be children who are eating out of or drinking out of lead glazed pottery, especially in Hispanic populations. We see quite a bit of that. Jewelry and cosmetics, like the little baby that you see with a coal around her eyes, different toys. And so I mentioned the lead water pipes, and of course we all know about that from the Flint issue. Different spices. I have actually had a number of children who, adolescents and young children, who have been poisoned by families who work at firing ranges or adolescents who work in firing ranges, people making their own fishing weights and sinkers or casting their own ammunition, and a lot of renovating. And we touched on that as well, and then about the need to do it in a lead-safe manner. Unfortunately, not everybody does that, so I've had people who have taken flame torches to walls to get the paint off and the wallpaper off, and of course making lead fumes where children have been poisoned. So who is at greatest risk? So we talked about children who are less than 3 years of age. We test at 1 and 2 years of age. However, obviously the whole spectrum of kids are at risk because of their high hand-to-mouth activity. We have a number of, obviously, immigrants and refugees and internationally adopted children who have less regulations in the countries that they are coming from. However, I can tell you that I just took care of a refugee child who, when she came into the country, was tested, and she was negative for lead, but then we tested her at her 2-year visit, and she was positive, and it turned out the home that we had allowed them to live in actually it was had lead, and so we had actually lead poisoned her here. And then children who live or attend a daycare in a home before 1960s, and this actually includes foster homes, and so this is something that we need to talk about, as we go forward. We need really good foster families, and oftentimes we have them, but we don't assess the home and the risk there for lead poisoning, and so we need to do that. And we talked about pregnant women as well. So what is the role of the healthcare provider? So you see here that I list screening and blood lead testing separately. And again, this is a conversation that I frequently have had with Mary Beth, where the role as the healthcare provider is to do that ongoing screening of asking, what those lead risk hazards are or what other environmental risks there are. And I would argue that those questions need to be asked even before the baby goes home from the nursery. And then at each visit for the well child checks, we continue to ask before the child is mobile and starts putting lots of things in her mouth so that we can prevent that lead exposure. We do need to provide that primary prevention because we know that is the only way that we are going to prevent lead poisoning. When you get the test, it's not too late because that helps us know where those lead kids are, but it's too late for that one child because the child has already been exposed. And so if we put a focus on primary prevention, that would be key, but we can't do that, so we also need our kids tested in order to find out where they are. And so that's why we do the blood lead testing at 1 and 2 years of age, and hopefully ongoing if we find children are in a high-risk area. We have to do behavioral and developmental assessments, as NSA mentioned. There is high risk for decrease in IQ and cognition and other behavioral problems. And so we have to do referrals to speech and hearing and do some neurodevelopmental testing. But this is where the problem comes from. If you look at screening versus testing, many people or providers out there in the world, or at least in the United States, the confusion is if I just do the screening questionnaire rather than the blood lead test, then I'm doing my due diligence. And Mary Beth has already said Medicaid doesn't pay for the screening questionnaire or that risk assessment. They pay for the blood lead test. And so while it's semantics and we have to use the terminology that CMS and CDC use because that's the way the law was written, we have to understand what the differences are. So many states have their own screening questionnaire. And so this is one from Missouri. I live in Missouri, so I can tell you. So we do universal testing and we do targeted testing, and I don't think that it's actually been approved by CMS, but we do it based on what we know where those high-risk areas are. And so we ask these questions, and do you have siblings that play or with lead poisoning? Do you live or visit in a house or a daycare built before 1950? And is there peeling paint chips in those homes? Do you have a lot of pica, which is eating non-food items? Do you play in bare soil? Do you, so we're asking these questions, and there are little asterisks by some of those questions about whether you are work with or has hobbies using lead. If you were just to give this to a family and they just read that question, they're not going to know, so they're going to put no. They may go down and look at what you mean, but not all things are going to be included in those appendices, basically, that gives you the definitions. This is Massachusetts, and Massachusetts has a lead law that requires all children be screened for lead poisoning multiple times through the age of 3. And of course, that screening that they talk about here is the lead. They get confused because they talk about it needs to be a screen, and is that the questionnaire or is it the screening test? And so many people or providers may get confused about that. This is another questionnaire that is done from New York, and they ask very similar questions that Missouri did. But again, if you look at the notes, they give the examples, but if something doesn't fall in those examples, the answer may be no. And then this is Washington State, where they also talk about doing targeted screening and targeted testing. They have an appendices, or an algorithm of who needs to be tested. Of course, all those children who are Medicaid need to have the screening test or have the blood lead test. But the question in the semantics makes it difficult for families or for physicians to know, even though they explain that the testing method is using either the venipuncture, which is preferred, or the finger stick by capillary to do that screening test. And then this is one from Florida. So you can see that they're all done differently, and they all have different risks that are listed on. This one asks the same questions, but in a different manner. Again, though, with some examples of an adult who may have a job or hobby that involves exposures to lead, but clearly can't be all-encompassing. So if you don't see something on there, then you're not going to answer yes. So we know that, again, as Mary Beth mentioned, that Medicaid and CHIP require the blood lead testing for children. And this goes along with American Academy of Pediatrics Bright Futures Guidelines, which is to do the blood lead test at 1 and 2 years of age. But even Bright Futures Guidelines recommends that a risk assessment or the questionnaire be performed at those well-child visits, as I mentioned, at 6, 9, 12, and 18 months, largely because those are the times of life where children have higher hand-to-mouth activity, where they're going to be ingesting that lead. And so if you get a positive on that lead questionnaire on the risk assessment, that's when you go forward, knowing that if they are Medicaid, they have to be tested. Again, a lot of confusion out there of what all of this of what to do, but it is described very well in many of these documents. But how it's actually told to physicians and what is required has been confusing, and has resulted in less blood lead testing in our children. So the AAP policy that was placed out in 2016 states that the children should be tested at least once when they are 2 years of age, or ideally twice at 1 and 2 years of age, unless lead exposure can be confidently excluded. And unless you ask the questions of every single question, I'm not sure that you can be confident in the fact that this child is not exposed. And so the default ought to be that you get your child tested. But really the focus in childhood lead poisoning policy should be a shift from case identification to primary prevention. But as Mary Beth Asherodt explained, if we don't know where those high targeted areas are, then we don't know, and thus we need to get the children tested. So I thought it would be good just also to, at the end here, to talk about cases that might have been missed if we hadn't been tested. And these are 4 kids that I've seen recently in my clinic, just to show you that it took it's following the rules basically of getting the child tested with the blood lead test rather than just going by the questionnaire. So actually in all of these, the questionnaire was done, and the children had actually, or the families had said no, and then we, by asking more questions, it was felt that the child needed to be tested. So the first one is that 2-year-old female refugee that I talked about, who tested negative for lead, who was entering the United States, but was tested positive 6 months later. When she came in as a 2-year-old, again, she was a refugee. If someone had just looked at the test coming into the United States, then found negative, then I don't know if some providers may have said, yeah, we don't need to test this child because she was negative and she was higher risk there than she is here. But what we were able to find is that she was in a home that was built before 1978 and had lead paint in the home, but actually the highest amount of lead, and most likely resulting in her elevated blood lead level of 23 micrograms per deciliter, was that she had these little beads on her shoes that they had bought here, but it was at a, one of those kind of giveaway where families bring in other clothes for the refugees, and there were these beads on the shoes that had high lead content, and the child had been chewing on them. The second one was a 1-year-old male who was previously bottle fed, and what is not talked about, especially when we talk about Flint, is the fact that children, but Ense didn't allude to this in her talk, is that children under the age of 1 are at high risk for the lead exposure in water because of the amount of water that they drink, especially if you're reconstituting formula. And so this is a 1-year-old who ended up having an elevated blood level at 8 micrograms per deciliter. And when we found the child at 1 year of age, we found that it was 8 micrograms per deciliter. But if we had done it at 6 months of age, where more water had been consumed, my guess is it would have been higher. And so some of these questions that need to be asked before the blood lead test at 1 may have prevented this child's exposure. Another one is, again, if you talk about occupations, we don't ask about oil fields. And we have a lot of oil fields in Kansas here. And there is a lubricant that they use on the pipes. We call it pipe dope. But it's actually very sweet, and it's very sticky, and it helps lubricate the pipes so that you can kind of screw them together. And the home was in 1990, and again, it was the mom who persisted in asking for the blood lead test, and it was 18 micrograms per deciliter. And again, we didn't find any lead in the home except for on Dad's uniform and his work clothes, because there was so much of this pipe dope that was on it. And again, it's sweet, and so the child had been licking it and had been poisoned from there. And actually, there was a nice study that was done out of Oklahoma state health department who had noted that this was a significant exposure that could happen in the oil fields. And then I already talked about this a little bit, but Dad's job was to work in a firing range. And again, if you look at occupations, it's not listed, and so they would say no, that I don't have this exposure. But the child was on Medicaid, so did get a blood lead test and was found to have an elevated blood level. And Dad's job was to pick up the spent bullets in the firing range and then shake them off to clean them, and then he would come home and not change his clothes. So you can see just by doing the risk assessment questionnaires, that's not enough. And if you don't delve in deeper, you're going to miss these kids, so they have to be tested. And so in conclusion, the risk from exposure to lead into children are high, and it really can be prevented. And while I would love to keep on arguing that primary prevention is key, and it really is, without the funding to actually do that, then we are kind of stuck in a place where we have to, we have to get our kids tested first to find out where those sources are. And many are not going to be picked up on those screening questionnaires, and so it's really up to healthcare professionals to follow the federal guidelines, which I know can be confusing as we talk about screening and testing, but we need them to follow on who needs to have those blood lead testing. And when you find an elevated blood lead in children, that's not prevention, but that is the way that we have to identify those who have been exposed. And so I'm going to leave you with this picture. Usually I ask people a question like if they know what anybody knows what this is, but I can't ask people. So this is the cage that they would put the canary in the coal mine, where they put the canary in and they'd put it down in the coal mine, and then they wait a little bit, and when they brought it back up, if the canary was alive, then they could go down and go to work that day. But if they brought the cage back up and the canary was dead, then, obviously there was an exposure. And so they wouldn't go to work that day until they could air it out. And so we continually put our children in as canaries in the coal mine or in the cage. We get them poisoned first, and then we do the assessment. And I think that that's backwards. We need to actually ask the questions first and prevent those exposures. But until we can get there, we have to find out who's being poisoned and who is not. And with that, I will end.
Thank you very much, Jennifer. So I have unmuted all the presenters. I want to remind everybody that if you have a question to ask everybody, if you will use the question window and type it in, then I will read the question to the presenters. We do have one question that's come in. I believe it's for the CDC presentation. Why were the blood lead levels presented only for non-Hispanic children presented? Does the CDC have data for children of different ethnic groups?
So it was just presented, and I'm not exactly sure which slide you're referring to, but we provide data, we collect and analyze data for all ethnic groups.
Okay. We actually have had a couple of questions come in about people asking for copies of the slides. What we do after the presentation later on this week, early next week, we actually send out a link to all the attendees, including the ones that registered but could not attend, with the recording link. And then we also give them a link to the other materials, including to the PowerPoint slides. Okay, so we have a person who's thanking all of you for the presentations. I think I'll give everybody a few more minutes to ask questions. This was a fantastic presentation, by the way. Sometimes it's hard to get four highly talented and experts in this field to present within an hour, and you guys did a fantastic job. So here's another question. It says, this is a question for Mary Beth. Any thoughts as to why only one state has sought CMS targeting? Is it a matter of unawareness by the states, lack of state level prevalence data?
So this is Mary Beth. I think I don't necessarily want to speak for states, but I think that that there is a lot of data that's required, and I think that places a high burden or high barrier for states to come in and request to be a targeted lead screening state. I also think that there are a limited number of states that have a higher prevalence in a targeted area. I think most states don't have that situation where there really are just certain areas of the state. So I think that there are a limited number of states that would probably meet the criteria, but we certainly are welcome to are happy to review any proposal that states submit.
Great, thank you. So that actually is the last question that we have received, because it is an hour later. If people have questions later on, we'll send a link to that they can email you directly. But I want to thank all 4 presenters for a fantastic and very educational presentation. I'm going to stop the recording and then log out. And then again, we will be sending a link soon so that you can actually review the presentation and do any kind of follow-up. So I want to thank Nseadu, Jennifer, Sharonda, and Mary Beth for this presentation, and hopefully everybody will also join us tomorrow for the presentation on Get Your Home Tested, same time, and again, you can register through GoToWebinar. Thank you all very much.